Danielle Chamie and Mike Gibson, and we are talking about intravascular ultrasound. Now, Daniel, I'm not an ultrasonographer. I'm mostly an angiographer. I do use, obviously, IVUS in my cases. Talk to us about the difference between what I do, which is squirting dye down arteries, and what you do, which is looking at the walls of those arteries. Help our audience understand the difference between a cath and an angiogram and
Mhm.
IVUS.
Yeah, so first, thanks for having me here, Mike. It's a pleasure. Yeah, so angio is basically a planar view of the coronary arteries. As you said, we just inject dye through a catheter, and then we outline the inner contour of the vessel. So we only see through X-rays where the blood is flowing from the inside, but we have no information about the disease in the wall.
So we're
So
looking at
atherosclerosis.
the inside of the pipe. I mean, it's like you were taking a picture of the pipe, but we don't look at the walls.
Exactly. No,
Hmm.
we don't look at walls. And we take a look at these pipes in multiple different views so we can have different perspectives of it. So we can appreciate stenosis and eccentricities, but we have no information about the disease, which is a disease of the wall. So atherosclerosis is an intimal disease, which is in the wall. So we don't see what is the component, what is causing that obstruction that we find by angio. And that's when intravascular imaging, in particular IVUS, as you said, comes into play because it's an intravascular ultrasound miniaturized in a catheter that we place inside the coronary artery and gives us cross-sectional images as the catheter is being pulled back. So we have like a spiral view from inside the vessel, and then we have much higher resolution than in geography, and then we can appreciate the presence of atherosclerosis, the major components of it. We can much more accurately quantify stenosis severity and so on.
Well, when I was in medical school, my professor was Seymour Glagoff in pathology. And of course, Dr. Glagoff taught us that the artery actually, when you get fat in it, it doesn't really get narrow for quite a long time. You have to have about 40% of the volume of the
Exactly.
artery gets fatter and fatter and fatter. Once you get a lot of fat in the wall, then it starts to get narrowed. So when I started my research back in 1987 on atherosclerosis, we were just doing angiograms to look at the narrowings. We weren't looking at the wall. And we missed a lot of disease and we missed a lot of improvement in disease. So, if someone has a normal looking angiogram, could they have plaque in the walls of the artery, even though they don't have blockages?
Yeah, absolutely. That's a great question. And actually, when we see stenosis or blockages in the angio, it means that we are in a much more advanced stage of the disease, right? So as you said, Glagov described what we call adaptive vessel remodeling. So when atherosclerosis starts to form, again, it's a disease of the wall, the inner part of the pipe. So nature makes the vessel dilate to compensate for the disease. So the inner part of the pipe is still unobstructed. And that's when you see normal looking arteries on angiography. But in fact, you already have some disease that's being compensated by adaptive remodeling or an adaptive dilation of the vessel to accommodate for the plaque. And as described by Glagov, when the relationship of the amount of plaque to the size of the vessel reaches up to 40%, then you extinguish the adaptive capacity and then you start to encroach the lumen. And that's when you find stenosis on the angiography. So yes, you might miss some early disease or plaques in the coronary arteries. And
Well, it's
actually
not
there's
just about, though, not just about finding plaque that we missed. There's a lot of lessons there about what's in that plaque, right? I mean, is it fat? Is it, you know, scar, fibrous tissues?
yeah,
Talk about what we learn about what's inside the plaque with IVUS.
yeah, once we miss those plaques, we're missing the composition. So most of the times, the major components are fibrosis. So most of the plaques have some sort of fibrosis, which is a scar tissue, lipid, which is, it's part of the development of atherosclerosis, and some calcifications as well, which is, a later stage of the atherosclerosis. But, the three components are oftentimes mixed along a vessel segment with disease. So the more lipid you have, more inflammation you have, and the thinner the fibrous cap that protects that lipid pool, the higher the risk you have. And there are many intravascular imaging studies in the past conducted looking at the progression of those plaques, the natural history of those plaques. And whenever we have large plaque burdens, whenever we have large lipid content, and whenever we have inflammation with thin caps that protect the lipid pool, the higher the risk. And these patients are under 4 to 7 times higher risk to have an event, an adverse event, as compared to a patient who doesn't have the disease or who have more stable phenotypes of that disease.
Yeah, it's kind of counterintuitive, right? I mean, you would think it was the tight ones, the really severe blockages, you're going to have a heart attack. That may happen due to a lack of blood flow. But the real dangerous ones, the ones that form a blood clot that really completely blocks the blood flow, those are the ones we're talking about that are maybe not as severe, but that lining of the blood vessel, the skin over the fat, is very thin and it can get torn and then expose the fat. And that's when you have a heart attack. So it's not just how severe the blockage is, but what it's made of. So your field replaced my field. We were using angiograms to look at all these blockages, but now we use angiograms to see, are we able to reverse the disease or stabilize it? What have we learned from some of those major trials that have been done with IVUS in that regard?
Yeah, so in that regard, IVUS allows us to, as you said, understand the composition of plaques. They're non-flow limiting. And I would like to make a statement saying that, the tight lesions, the most obstructive ones and the ones that have large plaque accumulated, those are the ones that have higher risk. The problem is the most frequent ones are the ones that are mild. And those are the ones that we eventually miss, and they may have high risk compositions that we might modify their, progression with medications and lifestyle modifications and so on. So there are many clinical trials with different pharmacological interventions looking at a plaque at baseline, and baseline means time zero when you start the treatment, and then you randomize patients to one arm on a medication and another arm on a placebo or on a competing medication, and you follow those patients up to, and depending on the clinical trial, it goes up to weeks to like 2 3 years, and you follow the morphological composition of the plaque. And what we have seen is that most of the times, high intensity statins, they not only modify the plaque, but they can regress plaque. They reduce the plaque volume over time. And that happens also for the new PCSK9 medications, um, um, LDL improving medications, and so on. So there are many anti-inflammatory medications, lipid lowering medications that followed over time can have a positive effect on regressing the plaque. And there are recent studies with optical coherence tomography, which is an optical analog of IVUS that gives us 10 times higher resolution to look into the coronaries. And now we can see structural changes in the lipid content and also the fibrous cap. And we also have studies showing that not only they reduce the plaque volume, but also they change the morphology and composition of the plaques, turning those from a high risk plaque into a more stable phenotype with less lipid and thicker caps that protect the lipid pool. And
And
therefore they reduce
talk to us,
risk.
where does this OCT and IVUS, where do they both fit in these days? I mean, if you were here in 2025 and you were doing a trial of a new drug, which would you choose? IVUS, OCT, or would you check even a different technology like a PET technology that looked in inflammation of the plaque?
Well, I think it depends on what endpoints are you interested on. So if you want to look at plaque progression or regression, IVUS is the best tool because it allows you to measure the inner lumen and also the external vessel wall, so we can have the full plaque volume. So that would be the number one technique. If you're more interested in structural changes in the plaque, then OCT would be better than IVUS because it gives you more information about local plaque inflammation through macrophage density allows us to measure the fibroscape thickness and get the arc of lipid. And when you add that on a length, then we get a volume of lipid. So there are more information about the structure. If the goal is to check on inflammation, then PET scan would be great. What I think those tools are going in the current era is a multi-imaging modality trial. So we have some combining IVUS, OCT, and NIRS, which is another intravascular imaging modality. So NIRS stands for near infrared spectroscopy, which provides a chemogram of the vessel and gives us the probability that that segment that we scanned has lipid. And once the amount of lipid over 4 millimeters is greater than 400, so you patient have an increased risk of events. So the most recent trials in the intravascular imaging space have been using multi-imaging modalities, sometimes separate equipment, some more recent combining NIRS and IVUS in the same catheter, or NIRS and OCT in the same catheter as well.
Amazing progress compared to when I started. Just so fascinating to see how things have shifted, moving from the inside of the artery to the wall where all the action really is. Not just is there plaque there, but what type of plaque? Is it fat or calcium? And now looking at inflammation, it's very exciting. Great time to be in this field. Daniel, thank you for joining us. Thanks for sharing all this.
Thank you, Mike. Thanks for having me.